On this episode of 26 Minutes with Dr. Warren Seigel, I'm joined by Dr. Mark Kindschuh, a highly respected and board-certified emergency physician with over 30 years of experience in emergency medicine, occupational and industrial medicine, and pre-hospital care. As the Chief of Emergency Medicine here at New York City Health and Hospitals South Brooklyn Health, Dr. Kindschuh has dedicated his entire career to providing high-quality, life-saving care in some of the most high-pressured situations. His expertise extends beyond the emergency room. He has specialized training in EMS and urban search and rescue, making him a critical asset in crisis response and disaster preparedness. Throughout his career, he has worked extensively in stroke management, addiction medicine, and community pediatrics, ensuring that patients receive comprehensive care that goes beyond immediate emergencies. Today, we'll be discussing a topic that affects all of us at some point: common accidents and injuries, and how to live and play smarter. Whether it's a slip and fall, a sports injury, or a workplace accident, understanding how to prevent and properly respond to these accidents and incidents can make all the difference. Dr. Kindschuh will share his thoughts on how we can take smarter precautions in our daily lives while also knowing what to do in the event of an emergency. Dr. Kindschuh, I'm so glad you're here. It's an honor to have you here on the show.
It's a privilege to be here. And so it's 35 years to be exact as a practicing emergency physician, trained originally at the first public hospital in the United States that started out as an almshouse, and that's Bellevue Hospital. So it's been a great journey. And I thought we'd start at the beginning in the homes in our community as to how I can reduce your chances of being a patient in this emergency department.
That's fabulous.
Obviously,
tell me a little bit about, where did you grow up? Are you from the neighborhood?
Oh, so I'm originally from Texas, attended medical school at the University of Texas, but I gravitated to New York in 1990 to start as an emergency medicine resident at Bellevue Hospital, NYU, where they launched for the first time an emergency medicine residency program under the leadership of a true pioneer in medicine, Dr. Louis Goldfrank. So I was part of the inaugural class in 1994.
And from there you came to Brooklyn, or what did you do in between?
Well, I married a girl from Brooklyn, so that pretty much sealed the deal on Brooklyn.
Okay.
And my wife, a practicing nurse, has been pretty steadfast that Brooklyn is our home, and I think we're blessed. We've raised 4 children, one of whom is will be entering a residency in anesthesiology, and one is now applying to medical school, and one's a lawyer, and one's works in a cosmetics industry, and they've all their education is Brooklyn based, and they're amazing kids, and it's I love Brooklyn. I consider myself a Texan, Texas roots. But Brooklyn has been a great professional life and home for me.
So when we talk about this community, you're part of the community.
Oh yes,
You're here. You're not just talking about it.
Listen, on my license plate is I'm Doc Blue. Okay, I was a medical director with at that time a rather small airline called JetBlue for about a decade, and I'm known in the community where we live in the summer times in the Rockaways. And the volunteer fire department, ambulance corps always calls us. Now, look, I'm nothing without the hospital and without a team around me of doctors and nurses, but I relish I'm sure you do, the fact that you can forget my name, but just call me Doc. That's what we love to do. We're physicians, and when you've done it for as many decades as we have, it's you are part of the community, and you want the community to be able to reach out to you and whenever they need you, whether it's a minor emergency or something catastrophic.
So tell me about, what are the most common things that you see in the emergency room?
Sure. So we see a lot of accidents and injuries, and the slips and falls are very, very common. Especially at this hospital, we treat probably the most senior population, aged population in the public health system for New York City. And it's very predictable. As you get older, your mobility decreases, your balance becomes impaired. This is natural aging. And your eyesight begins to diminish, your hearing diminishes, and so then your risk for a fall, higher risk than you would be otherwise. Accidents, though, the premise of this realization, okay, you're here with an accident, are you at risk for an accident? Yes. Is it preventable? Well, accidents can be mitigated, meaning you can't, put things down to some zero, but you can do things in a household. Now, sometimes you'll need help to get there, but look ahead. Try to prevent the accident. I go into homes of older people often, and I find the lighting is very low. Well, the lighting is low because your vision is becoming gradually more reduced, and you don't have the perception that the lighting is low. You just know you can't see too well. But lighting is important. And in an older person's home, if there's the ability to increase the lighting and even put in automatic lighting, you walk down a hallway, the light turns on, turns itself off. These are things that can help a visually impaired older person from, striking an object that may be in the way. We are all hoarders to some extent. We like to collect stuff. We're human beings. We just love collecting stuff, And, but not all stuff clutter is dangerous. Clutter should be moved from hallways, stairways, things like this. The other day I had a call from a family member who it was noted that she was descending the stairs using the wall to balance her. Well, there's a handrail on one side, but not a handrail on the other side. A handrail will be placed on the other side. Around a toilet. A toilet paper dispenser is not appropriate to lift yourself up from the toilet bowl. It'll break. You'll fall. You will injure yourself. At times, as we become less agile, we need devices to help ensure that our risk of falling is less. 30,000 individuals a year. Now, it starts as a fall, but 30,000 people die as a direct result of a fall.
Wow, 30,000.
Now, we're a country of 300 million. We're a big country.
But that's 30,000.
That's a lot of parents,
a lot of
uncles, aunts, mothers, brothers who die as a result of something potentially preventable.
It's interesting. It reminds me, I had a friend many years ago who used to say there's no such thing as an accident. There's a cause to everything.
Correct.
Things don't just happen. So what you're saying is that we should start looking around our environment and figure out how we can decrease the likelihood that these slip and falls are going to happen.
First just start with the people that you know when they're home, and you'll find area rugs that are slipping in a hallway. Now, that area rug may have been in their possession for 20 years, but it's time to go. It's got to move. When you get older, you begin to don't lift your feet as easily from the ground. You'll shuffle more, and even something with a half-inch rise could be enough to trip you. And now, so kids are also at risk for falls under the age of 5, but they bounce. For the most part, they bounce. Older adults don't. Bone density diminishes. Look, it's part of aging. Now, you can do things to slow that diminishing bone density, but it's about 3% a year, every year after 50, generally. Now, if you work out a little bit, you use some exercises that provide a loading form of exercise, like little weights, that can help reduce the diminishing bone density. Vitamin D, calcium supplements, as evaluated, prescribed by your doctor. Getting these levels checked also as a part of preventative care medicine is very important. But the fact is that when an older adult falls, they're more likely to fracture bone. And we see in the emergency department commonly wrist fractures in older patients because you're putting your arm out to brace yourself as you fall, broken wrist. Humeral fractures or upper arm fractures, very common. And then unfortunately, which are life-changing oftentimes, hip fractures as you fall on the side. So you were at high risk not only for injuring with fractures, but also dying, especially after the age of 80, 85. And that population are the people who would most benefit from someone looking at the house and in a caring way, helping these individuals reduce their risk of falling.
This is fascinating. When I think of an emergency department and a patient going to the emergency department, I always think of heart attacks. I think of strokes. I think of these major medical problems.
Sure.
But here you're talking about something that is so easily checked before they happen. We're talking about prevention. So looking around our environment and the environment of our loved ones and really doing a risk assessment.
And we do very often when we have older patients who arrive for whatever reason. Our first information often comes from we don't have family with them, from our pre-hospital care providers, our emergency medical personnel, about the conditions in the home. And we can sometimes get a sense of whether or not that home is safe to return to, in the most extreme types of description.
Wait a minute. So when my kids call 911 and they bring me in, somebody's going to tell you the condition of my house?
So everything's about your safety. And so we understand, this department certainly understands, and we work with a very talented group of case managers. These are nurses who then are skilled in applying social services to patients, understanding the ins and outs of insurance and whatnot, to determine if that individual helped the medical team, guide the medical team to what is the safest, what we call disposition. Is home, going back to home, the best disposition for them or not? And now listen, everyone, as long as someone has capacity and is independent, able to make a decision, whether it's a good decision or a poor one, if you understand that a poor decision has risks, that's okay. No one wants to take away anyone's independence. And that's why it's important when you approach older individuals about options that can improve their safety. Be gentle and do this in a way that you be kind. But most of us appreciate a little assistance when we need it.
So that's really interesting. I immediately started thinking, well, I better start taking better care of my house. It's a little dusty. I better get a cleaning lady.
Again.
So you're really doing an assessment for me when I come into the emergency room if I've had to slip.
So we get many falls that don't have then injuries that are surgically correctable, and the patient does not require coming into the hospital for surgery or whatnot. Thankfully, okay, but they're injured. Now they're sore, they can't ambulate well, and we have to determine how this older person can return home. The sooner the better, because home is where they say home is where the heart is. Home is where most of us want to be as we get older. We get less and less inclined to want to be in a skilled nursing facility or certainly a hospital. So our goal is to evaluate an older patient who falls for any medical or surgical condition that may have led to that fall or the consequence of that fall, and then work with our team to manage the discharge, the disposition, in a way that really promotes the safety and dignity of that person.
So tell me, when should I call 911?
Sure.
When should I call an ambulance?
Yeah.
I'm not going to come to the emergency room for every little thing. When should I say, I need help?
Yeah. So you should when you feel, honestly, it's sometimes the difference between a panic attack and an actual heart attack very indistinguishable to a person. So if you feel like you're dying, I need help now. Okay, but when we look at what are if someone's calling for you, you're calling for yourself. If you're, it's hopefully you're with somebody when you sustain something that's really potentially life changing. But anytime someone's unconscious, there should be an immediate call to 911. And I think some of us, have a fear of doing cardiac compressions on a person. And I still hear the term mouth-to-mouth resuscitation used, like, oh my gosh, I can't, what if I catch something, or if there's vomit or something. Well, actually, we have hands-off CPR, which really means that hands-only CPR, which means that you, on an unconscious victim, check for a pulse, or if you can't feel a pulse, or you kind of have that sense that person, not breathing and potentially doesn't have a pulse, just start CPR right away, meaning over the breastbone or sternum, begin to do compressions about 100 times a minute. I mean, just as fast as you can, essentially. And no need to rescue breathing, because already in most individuals who collapse, there's enough oxygen dissolved in the bloodstream to last, about 5 minutes or so, while someone calls 911 and rescue arrives. Now, in terms of other reasons to call, anytime you're having crushing chest pain, person's sweaty, obviously could indicate an acute coronary event. Signs of stroke symptoms, difficulty talking, confusion, it could be transient or lasting, weakness on one side, even numbness on one side, all suspicious signs for stroke. Severe abdominal pain that's persistent, not going away, vomiting of anything that's either dark or red, high, unrelenting fever, severe headache that's piercing, especially associated with vomiting. But it really is the sense that if that individual looks bad, if that individual really feels terrible, that's time for an ambulance. In New York City, the fire department, because most of the ambulance transport, essentially assesses whether that's a high acuity condition or a lower acuity condition. And the lower acuity conditions, often the description is a sick call. Because of the volume of patients that are transported to area emergency departments, that can take, it's not a handful of minutes, it can take tens of minutes to receive that call. I understand clearly that folks who travel by subway, don't own a car, things like that, that it's, the system here exists for the public service. One question I'm asked, and actually a recent decision by FDN, by the Regional EMS Council in New York State, a decision was made that low acuity conditions, that the patient, now the ambulance patient, cannot request where they want to go. So I say, please take me to XYZ hospital. They can say, our system is that, ABC hospital is closer. We have to take you there.
So when I call 911, they're going to take me to the closest hospital?
Yeah, first they'll determine if your condition is a high acuity condition, like a stroke, a heart attack, trauma. They're going to take you to a hospital that has those services available. Not all hospitals do. If it's a lower acuity condition, I'm having a bad stomachache, then they will say, we understand that's where your doctor is, but we have to take you to this hospital because it's the closest. The reason that is that it's for the greater good to the public to have ambulances in the area dispatched to closer hospitals so they can get back on the road to then attend to the next call.
Well, that certainly makes sense. You were saying this is a change?
It's
so
actually
I used to
changed.
be able to say, hey, drive me to Manhattan.
Yeah, it's
because
a
I
change.
like
In fact,
that.
I just received it on an email today
Really?
from one of my colleagues at another hospital.
So it sounds like the take-home message here is if you're scared or somebody is worried about your condition,
Yes,
call 911.
absolutely.
And don't worry about, saying, oh, that was a mistake. It's better safe than
I
sorry.
mean, we discharge from our emergency department 85% of our patients who come in. So, and I never say, don't call me again.
Mm-hmm.
Why were you fooling us? No. I mean, we thank God the human condition is resilient, and that for the most part, we are able to send our young folks and our older folks home. So no, you're not going to get any sort of an angry letter saying, why did you call for an ambulance?
That's interesting. 85% of the
Yes.
patients seen who come in by ambulance are discharged home?
Not necessarily by ambulance. Ambulance actually, that's closer to 50%.
But even that, so just because I call an ambulance doesn't mean that I'm dying, doesn't mean I'm going to be admitted to a hospital. So for those of us who are afraid of going to an
No, there should be no
emergency room,
fear.
it doesn't mean you're going to be admitted.
Not at all.
But it does mean you're going to be seen and assessed and treated, and hopefully you beat the 50% who get to go home.
As we like to say it, you'll be treated and treated.
Treated and treated. So you talked about hands-only CPR. You talked about when to call 911 and get help. You talked about going to the closest emergency room. Are there times when things should be treated at home? So you mentioned a first aid kit.
Sure.
I don't know if everybody has a first aid kit.
Well,
at home.
I think that first aid kits are variable, but typically they contain something to control bleeding. meaning a direct, I don't know how many patients I've seen come in with a towel wrapped around an area. And often it's poorly wrapped, it's large, cumbersome, and the bleeding just continues. So sterile gauze pads are certainly part of it. Tape, so you can tape something around bleeding, because bleeding works, it stops with direct pressure. Lacerations are common at home, as are nosebleeds, things like that. So something to control bleeding, usually if you get an abrasion or scrape, or even a cut, some sort of salve or ointment to put on it, even as you go to the hospital with that. Other things include a sling for you injured your wrist, your arm, but something to hold so that because it helps the person who's being transported to not move the arm, and it just makes that transfer a little bit more comfortable. So an arm sling, plastic bags for vomiting, things like that. But in addition, and which you don't see in kits, but what you should have in your home kit are a couple of life-saving things. One, certainly Narcan. So Narcan is a drug that is an antidote to opioid poisoning. And just put this in mind: 1 in 5 kids, teenagers, has already experimented with prescription medications. And if they have, and for example, then another friend or mate at a party or whatever on the street says, "Hey, I got a Vicodin, take this." Remember, 1 pill can kill. Vicodin, adulterated, but Vicodin, Adderall, these different, OxyContin, other prescription meds are very often adulterated with fentanyl by drug dealers, and this can be fatal. And so having Narcan in your home can be life-saving, and knowing how to do this, it's provided a little spray by intranasally and twice, and it can be the difference between life and death for that individual.
So simple spray up the nose.
Yep.
And what if they passed out and it's not because of a drug overdose? If I do that, is that going to hurt them?
No, not at all. It has no ill effects whatsoever.
So it sounds like we need to start looking around our environment, our homes, our
And
apartments.
Narcan's available without prescription from your pharmacist.
That's exactly what I was going to ask. And make sure we put together a first aid kit
that
has Narcan as well as all the things you mentioned.
And another thing. I'm neither invested in or a customer of this product, but choking in the home is another. By the way, most overdoses from opioids occur in a home. These are not on the street and shooting galleries, X, Y, Z. These are in homes. In regards to choking affects both the little ones and older adults. Older adults, perhaps Parkinson's and whatnot. And then how do you prevent that? Cutting the food correctly, slowly, chewing. How often do we tell our kids, don't talk with your mouth full? Often talking, laughing one time, then aspiration of a piece of food, grapes, things like this. But there's a device that is sold on the market that is able to, it's put over the face, the nose and mouth, and like a suction, almost like a toilet plunger. You push it down and then pull it up, and it sucks the foreign body or food particle out of the oropharynx. Better than stomach thrusts, abdominal thrusts, or back blows. I haven't seen it applied for infants, but I've seen it on toddlers, school-age children, and adults. I think it's LifeVac, I think is the name. But these are things that can be, again, what can you do to safeguard your home when that unanticipated incident happens? I mean, life happens. But if you're better prepared, you can hopefully, God will bless you with a better outcome.
So I hate to end on a depressing note, but what's the worst part of being an emergency medicine physician? Obviously, some patients don't make it. I'm assuming that's got to be the worst part.
You have to learn how to cry with your patients. The first time I cried was back in the day. It was a 500-gram twins I had, and I was caring for them. And it was clear from the more seasoned members of the neonatal ICU that this child would die. But it was my first experience, And I just remember driving home and being completely overwhelmed. So you have to keep that in you have to keep your composure. That's the most difficult thing sometimes. And some of the doctors, one of the doctors who works with me currently, works with me. Yes, he's an employee. I admire him so much because I saw him in his own moment lose his composure in a very difficult case. And I knew then how dedicated he is to our work here.
Thank you.
Oh.
And thank you for what you do every single day.
Thank you.
And thank you for giving us some real concrete tips of how we can be healthier
Sure.
and hopefully not become one of your patients tomorrow.
Yeah, that's right.
Thanks so much.
You're very welcome, Warren.
And that brings us to the end of our program today. Thank you for tuning in and learning alongside of us. For more information about our show, please visit us at www.zormed.com and stay updated with South Brooklyn Health by visiting us online. This broadcast was brought to you by Brick Media in partnership with New York City Health and Hospitals, South Brooklyn Health. Until next time, be safe and stay well.